So what we found that if that was true, if you cut coverage for the atypicals, meaning that Medicaid patients are too poor to be able to afford them on their own, you would lower spending in the Medicaid schizophrenic population by 90%. Because these, first generations are generic, second generation are brands. However, by doing so, you would impact health negatively of an equivalent of 98% of class spending. And the reason was that in the indicated trial data, many people who failed first line responded well on second line therapy or second generation therapy. So many people who did not respond on generics would have responded on the brand name drugs. Medicaid responding to the CER in this case would eliminate that option, and that would hurt health of the population. And it turned out that it hurt health more than it actually increased or decreased spending. So I think that's an example of walking through essentially this kind of analysis we did. We say essentially, here's how the private market is going to respond, which is exactly what happened here, that second generation therapies took a hit in the market, spending went down relative to before. First generation therapies were the winners. They were more cost effective, being declared equally effective. And their sales presumably rose in the market, which we have data on as well. So that happened. Now market responded before the payers responded. Now Medicaid comes in. What is the payer response? Well, the payer response is trying to restrict some way or another based on this evidence, coverage or reimbursement for the loser in the trial, or loser in the CR study, in this case, second generation therapy. And due to the heterogeneity, due to this negative dependence that some people who fail one drug will do well on others, you got this negative health impact here, which was larger in this case than the reduction in spending from going on a generic drug. So I think in general, it is, from my perspective, I haven't seen clear discussions of how CR will work. I know we have a lot of evidence being generated. I don't think anyone has a good understanding of the impact that evidence is going to have. Saying that it's going to lower spending and promote health, I think is a little naive. Or, I mean, it just means that you haven't thought through the process. Clearly, payers will respond to this evidence. There's no question about that, I think. They're not just going to sit there and have winners and losers declared and then not have their reimbursement coverage policy respond to that. Clearly, the market will respond to it as well in predictable ways. So how do you move forward in terms of generating better evidence? Well, clearly you need to move away from product-specific conclusions because products, there's no winners and losers for everyone. Seldom is that the case. So the question is, how do you get most efficiently the products that work into the right patient? And we're developing, as an outgrowth of this paper, we're sort of developing better evidence metrics that could be used in CR studies than just doing the standardized sort of gold standard, which is the randomized clinical trial. We have essentially marginal treatment, means average treatment responses in the two groups. Like I said, that's not very informative for practice, because many times in practice what you're interested in also in saving money is when you have information that failure has occurred in the past, do you continue? And that question needs better evidence to be generated about what a randomized clinical trial is essentially telling you what is the best first-line therapy. That's the only thing it's telling you, because it's telling you if you don't know anything else, how well does the average person do on a given therapy. But it doesn't tell you how you move down the line. And that's going to have dramatic consequences. Right now, I think the implicit understanding I take it is CR will rank treatment effects in trials, and then we'll have first, second, third line therapy depend on that ranking. That could be extremely misleading, as it was using the Katie trial for that purpose. And what metrics need to do is to basically tell people who practice medicine more useful information, which is about this joint distribution about treatment effects. If you don't respond on the first line, do we know something more than before you didn't respond? Yeah, we do. Maybe we know that you're never going to respond, or on average, people never respond to second when they failed first. And that kind of evidence, I think, is crucial to be more useful for clinical practice. I think I will end there and take questions. And here's phone numbers and emails if you're a little shy and want to ask me questions some other time.